Welcome back to the deep dive. Today, we're really immersing ourselves in something quite fundamental, aren't we? Comfort, sensory perception, and pain management.
We are. And these are topics that, well, everyone feels they have a handle on.
Mm.
But when you actually look at the core medical and educational materials like we did for this deep dive,
Yeah.
you start to see just how subjective, even fragile, our internal reality can be, how easily it's influenced.
So our mission today isn't just about, defining terms from a textbook.
Yeah.
It's more about uncovering these really powerful, sometimes surprising external forces.
Things like culture, medication,
Mm-hmm.
things that fundamentally shape how you, listening right now, perceive the world.
And specifically, how you experience pain. That's a big one.
Definitely. So we've basically got two main areas we're navigating today based on the source material.
Okay.
First, looking at comfort and our sensory experience,
Mm.
how external factors can sort of break down or manipulate our sensory systems.
Right. And the second,
The second is introducing the principles of pain management, getting into what it means for pain to be this ultimate subjective truth, the fifth vital sign, and how we even begin to manage it.
okay, let's start with that first part then. Comfort and sensory perception. We all learned the classic five senses in school.
Vision, hearing, taste, smell, and touch, or tactile perception, all linked to specific receptors in the body.
But the really fascinating thing jumping out from our sources isn't just listing the senses, it's the variables, the things that completely change how a person takes in and interprets stimuli.
Exactly. Perception isn't static. It's not like measuring height. It's fluid. And age. Age is probably one of the most profound physical factors.
Oh, so.
Well, forget the visible stuff like wrinkles for a second. The real surprise, neurologically speaking, our sources highlight that in older adults, the actual nerve conduction fibers decrease in number. The system's wiring thins out, essentially.
Wow, so that's not just about moving slower physically.
No, it impacts perception itself. You perceive things slower. Fewer nerve fibers means signals travel slower.
So, slower reflexes. A delayed response to things like pain, or maybe a sudden noise.
Precisely. And then you layer culture on top of that physical change.
Right. Culture dictates so much. Acceptable eye contact, personal space, how close is too close.
Even the use of touch. In a healthcare setting, understanding these cultural nuances is absolutely critical.
Because what might be comforting sensory input in one culture.
Could be really unsettling, maybe even sensory overload in another. Huge difference.
And we definitely have to talk about medication here. This seemed like a really crucial point in the material.
Oh, absolutely high impact. The sources specifically call out drugs that cause sensory shifts. Take really common ones like aspirin or the diuretic Lasix.
Yeah.
You might not think about it, but they're known as ototoxic,
Ototoxic, meaning
meaning they can actually damage the structures in your ear responsible for hearing.
that's quite a risk, and probably one a lot of people aren't aware of.
Very likely. And then on the other side, you have things like opioids or sedatives. Their whole purpose is to decrease stimuli.
Right, to calm the system down, turn down the volume on the sensory world.
Exactly. Necessary sometimes, but it definitely alters your baseline reality while you're taking them.
And the sources mentioned other factors too, briefly. Stress, illness.
Even personality and lifestyle. If you're someone who runs high on anxiety, your sensory world is already kind of dialed up, right? Before anything else even happens.
That makes sense. So all these factors lead us to the idea of sensory alterations. The source material talks about a spectrum here.
Yeah, it does. On one end, you've got sensory overload. Just too much input, constant bombardment.
Like a chaotic, noisy hospital ward. Or even trying to focus in a super bright, busy office.
Perfect examples. And then the opposite, sensory deprivation. Not enough stimulation.
Which can be just as bad, can it?
Absolutely. Think about someone isolated at home, maybe an older adult, or a patient stuck in a quiet, dark room for days with little interaction. Both ends of that spectrum cause real distress.
And then there are the specific deficits the material mentions. Impaired touch, vision problems, hearing loss.
Taste and smell deficits, too. The key takeaway here for you listening is really about recognizing the cues. Those subtle signs that someone might be experiencing overload or deprivation.
And then implementing ways to minimize that negative impact.
Exactly. It's about managing the environment and the input.
So the big picture from this section seems to be just how easily our perceived reality is shaped, maybe even manipulated, by factors we often don't think much about. Our age, our culture, what's in our medicine cabinet.
That's a great summary. And if that's true for something like sight or sound,
Then imagine how easily the most subjective experience of all gets influenced. Pain.
Perfect transition. That takes us right into our second pillar, the concept of pain itself.
Hmm.
And if there's one single, absolutely definitive statement about pain from the medical sources we looked at, it's this.
Okay.
Pain is whatever the person experiencing it says it is, and it exists whenever the person says it does.
That is radically subjective, but foundational, you're saying.
Right. Absolutely foundational. It means the client's own self-report isn't just helpful information. It is the single most reliable diagnostic measure of pain, period.
You have to believe the person experiencing it.
You have to. And this idea is so critical, we've actually formalized it in practice, haven't we?
Yeah, pain is officially called the fifth vital sign.
Measured and documented right alongside blood pressure, heart rate, breathing rate, and temperature.
Which really elevates that subjective experience, doesn't it? Puts it on par with objective physiological data.
It does. Now, trying to measure something so internal, so subjective, it's tricky, so we rely on standardized scales. Self-report scales are the gold standard.
But what about someone who can't verbalize? Someone with advanced dementia, for example.
Good question. The material specifically mentions the Panet scale in those cases. It's designed to assess pain by observing things like breathing patterns, any vocalizations, facial expressions, body language.
Okay, so there are tools even when direct self-report isn't possible.
Yes. Now let's get into a really crucial distinction the sources make. Acute versus chronic pain.
Because they're treated very differently, right?
Worlds apart in terms of goals. Acute pain. That's the kind most people think of first. It's temporary, directly linked to some kind of tissue injury, and it generally resolves once that tissue heals.
And it usually comes with very obvious physical signs, like an alarm system going off.
Exactly. You see clear, measurable physiological responses. Heart rate goes up, tachycardia. Blood pressure rises, hypertension. People often feel anxious. They might sweat. The clinical term is diaphoresis.
Muscle tension, too, I imagine. And behavioral signs.
Oh, yeah. Grimacing, maybe moaning, definitely guarding the injured area. And because there's usually a clear underlying cause, the treatment targets that specific cause.
Okay, so that's acute pain. What about chronic?
Chronic pain, well, that's the one that lingers. It's ongoing or it keeps coming back, lasts longer than 6 months, typically.
Yeah.
Often way beyond when any initial tissue damage should have healed.
And here's the really counterintuitive part the sources highlighted. Those physiological alarm bells, the vital signs, they usually don't change much in chronic pain. Is that right?
That's exactly right. It catches people by surprise. Someone could be in constant pain for a year, but their heart rate, their blood pressure, might look completely normal on paper.
So the body adapts physiologically.
It seems to. The burden shifts. Instead of that acute physical upheaval, chronic pain really impacts the psychological and functional aspects of life.
So you see things like depression, overwhelming fatigue.
Yes, and a real decrease in the ability to function day to day. And because the original physical cause might be gone, or maybe it's just not fixable, treatment has to shift focus.
To managing symptoms, improving quality of life.
Precisely. Symptomatic relief becomes the main goal.
The sources also expanded the vocabulary beyond just acute and chronic, didn't they? Listing different types based on origin.
They did. It's helpful for classification. Things like visceral pain, which is pain coming from deep internal organs.
And radiating pain. That travels along a nerve path.
Yep, like sciatica. And then there are those fascinating cases where the wiring seems a bit crossed.
You mean like referred pain?
Exactly. Pain showing up in your shoulder or jaw during a heart attack. The problem's in the heart, but the pain signal gets interpreted somewhere else. Understanding that is crucial for diagnosis.
Definitely. And the classic example of the mind or maybe the nerves playing tricks. Phantom pain.
Right. Feeling pain or sensation in a limb that's been amputated. It's not physically there, but the neurological sensation is absolutely real to the person.
Incredible. The sources also mention psychogenic pain.
Yeah, where extensive investigation finds no clear physical cause, and also neuropathic pain, which is pain arising directly from nerve damage itself, often described as burning, tingling, shooting.
So understanding these different categories is really the first step towards figuring out the right intervention.
It has to be. Okay, so let's transition now. We've talked about perception, define pain. How do we actually assess and manage this deeply subjective experience? Because the factors influencing it go way beyond just the injury itself.
They really do. Pain isn't just a physical signal, is it?
Not at all. It's more like a composite score. Biology, psychology, personal history, it all feeds in. Age matters again. Older adults often have multiple health issues happening at once, making it harder to isolate one source of pain.
An emotional state plays a huge role too, right? Fatigue, anxiety, fear.
Absolutely. They can all amplify the pain signal. Prior bad experiences with pain can actually lower your threshold for future pain.
And your support system, coping mechanisms.
Hugely important. And again, culture and cognitive function are always modifying factors in the background.
Which leads us to a pretty fundamental principle that drives how we approach this.
The right to management. The sources state clearly, clients have a right to adequate assessment and management of pain.
And nurses, or anyone providing care, are accountable for making sure that happens.
Accountable. It's not just a nice to have. And undertreatment isn't just uncomfortable, it's listed as a serious complication. For acute pain, undertreatment just ramps up the anxiety, maybe slows down recovery. For chronic pain, failing to manage it effectively worsens depression, leads to more functional decline.
Yeah.
It's a downward spiral.
So to combat this subjectivity and avoid undertreatment, we need a systematic way to assess pain.
Exactly. And the sources strongly advocate using a structured mnemonic, the OPQRST method.
Ah, yes. OPQRST, it forces a kind of objective framework onto that subjective report.
It does. Let's break it down quickly because it's actually a useful structure for anyone trying to explain their own pain to a doctor.
Good point. Okay, O is for onset.
When did it start? Pretty straightforward.
P is for palliative provoking.
Right. What makes it better? What makes it worse? Heat, cold, movement, rest.
Q is for quality.
What does it actually feel like? Sharp, dull, aching, burning, throbbing. Getting those descriptive words is key.
R is radiation and region.
Where is it located? Does it stay put or does it spread or travel somewhere else?
S is severity.
Usually the classic 0 to 10 scale.
Yeah.
0 being no pain, 10 being the worst imaginable.
And finally, T is for time.
How long does the pain last? Is it constant? Does it come and go? Intermittent? What's the pattern?
Using that whole framework, OPQRST, really ensures a comprehensive picture, even though the core feeling is subjective.
Exactly. And of course, when someone can't give you that verbal report.
You rely heavily on nonverbal indicators, the body's signals.
Right. Observing facial expressions, grimacing, wincing, body movements. Are they guarding a specific area? Pacing restlessly?
Moaning or crying.
Yep. And often, a decreased attention span. The pain can just dominate their cognitive space, making it hard to focus on anything else.
Okay, so we assess thoroughly. Now, interventions. The sources emphasize timing here.
Timing is critical. For persistent, ongoing pain, like chronic pain or postoperative pain, the strategy has to be around-the-clock intervention.
Meaning you don't wait for the person to be in severe pain and ask for medication.
Absolutely not. You have to stay ahead of the pain curve. Give analgesics before the pain gets bad.
Or before activities you know will cause pain.
Exactly. If someone needs physical therapy, they should get their pain relief before the session starts, not struggle through it and get medication afterwards.
That makes sense. And there was a special note about older adults again, wasn't there? A kind of double-edged sword.
Yes, a real balancing act. They're at higher risk for undertreatment sometimes due to assumptions about pain perception or tolerance in aging.
But also...
Also at higher risk for adverse effects from the pain medications because their metabolism might be slower, they might have other conditions.
So it requires really careful, individualized dosing and monitoring.
Very much so. And crucially, pain management isn't just about pills or injections.
Right, the non-pharmacological measures. The sources had some really practical takeaways here.
They did. Things listeners can potentially use or advocate for, starting with basic comfort.
Like ensuring bed linens are clean and smooth, positioning someone comfortably.
Elevating swollen limbs to reduce that pressure and edema. Simple things, but they matter.
Then there are more active physical strategies.
Applying heat or cold where appropriate. Localized massage. Therapies like acupuncture were mentioned.
And then the cognitive and behavioral strategies, these seemed quite powerful.
They can be. Distraction is a big one.
How does that work?
Anything that shifts focus away from the pain, getting up and walking if possible, deep breathing exercises, having visitors, watching TV, listening to music, even prayer for some people.
And more formalized techniques.
Things like guided relaxation, meditation, yoga.
And imagery.
Yes, imagery, deliberately focusing your mind on a pleasant thought, a calming scene or memory. It helps divert attention from the pain signals.
But the source made a key point about imagery, didn't it?
It did. It requires the ability to concentrate, so it might not be suitable for everyone, particularly someone with cognitive impairment or who is acutely distressed.
Okay, so if we try to synthesize this whole deep dive, what's the core insight?
I think it's the sheer complexity and subjectivity of it all. Comfort, sensory perception, pain. These aren't simple inputs and outputs. They are profoundly subjective experiences.
Shaped by everything from, like you said, the state of our nerve fibers to our cultural background, the drugs we take, our anxiety levels.
All of it. But the definitive takeaway, the point the medical sources hammer home about pain,
Is that it's defined only by the person experiencing it?
only by them. And their self-report is the most reliable measure we have. We must start by believing them.
Which really leaves us with a fascinating question to mull over, doesn't it? For you, the listener.
Go on.
If we accept this principle that in the high-stakes, evidence-focused world of medicine, the subjective report of pain must be treated as the ultimate authority, how does that change how we think about subjective experience more broadly?
Beyond just pain.
Yeah. What else in life, what other internal states or experiences should we perhaps grant that same level of authority simply because the person experiencing it says it is so?
That is definitely something to think about. A challenging thought to end on.
Indeed. Something to consider until our next deep dive.